దీన్ని స్క్రోల్ చేయాలి సార్, పీడిఎఫ్ కాదు, స్క్రోల్ చేసుకుంటే.
Good afternoon, everybody. Today we shall discuss regarding the infections during pregnancy. What are the various infections and how to treat them if they are along with pregnancy. Types of infections are bacterial infections, viral infections, fungal infections, parasitic and protozoal infections. Coming to the bacterial infections, group B streptococcal infection. The main organism is Streptococcus agalactia. That's the main bacteria. Risk factors are early onset neonatal infection, include positive prenatal culture for GBS in this pregnancy, and preterm birth of less than 35 weeks of gestation, and premature rupture of membranes for longer than 18 hours, and intrapartum maternal fever greater than 38 degrees. Then how to screen them? To manage them, CDC, that means Center for Disease Control and Prevention, recommends intrapartum antimicrobial prophylaxis for preterm labor before 37 weeks of gestation. Duration of ruptured membranes longer than 18 hours. Intrapartum temperature greater than 100.4 degrees Fahrenheit. The treatment is penicillin G, ampicillin, and cefazolin, are the drugs of treatment. And next, coming to the tuberculosis in pregnancy, symptoms of tuberculosis during pregnancy are risk factors for TB are positive family history or past history. Positive family history or past history of tuberculosis, low socioeconomic status, area with high prevalence of tuberculosis and HIV infection, alcohol addiction, and intravenous drug abuse are the risk factor for tuberculosis. Coming to the clinical features, here the patient complains of cough, weight loss, sleep, sweats, so sweating during sleep, and evening pyrexia, malaise, and fatigue, enlarged lymph nodes, or pleural rub. These are the clinical features for the patient with tuberculosis. To diagnose, we have to do tuberculin skin test and X-ray chest, early morning sputum, 3 samples for acid fast bacilli, and gastric lavage and diagnostic bronchoscopy, extrapulmonary sites or lymph nodes, bones, rare in pregnancy. So this is extrapulmonary site like lymph node enlargement and bony involvement is rare in pregnancy. Effect of pregnancy on pulmonary tuberculosis. Pregnancy does not worsen the clinical course of tuberculosis. Effects of tuberculosis on pregnancy is the fertility rate is low, higher incidence of toxemia, preterm labor, postpartum hemorrhage, and difficult labor in pregnant patients suffering from tuberculosis. Maternal fetal prognosis is good, and therapeutic abortion is not necessary except in a patient with multi-drug resistance. Effect on the mother. The effect of tuberculosis on the mother is pregnancy may worsen the maternal outcome in drug-resistant patients, and medical termination of pregnancy may be considered in selected cases. Effects on the fetus. Effective chemotherapy has reduced the incidence of low birth weight, and streptomycin use was associated with congenital deafness. Treatment nowadays is rifampicin, isoniazid, ethambutol, pyrazinamide. These are the drugs of choice. Newer anti-tubercular drugs include clofazimine, ciprofloxacin, ofloxacin, amikacin, clarithromycin, and azithromycin. These are the drugs of choice in the treatment of tuberculosis. Then the obstetric management in pregnancy, in labor, breastfeeding, and contraception. So this is during these conditions, you must know how to manage tuberculosis. Then coming to the bacterial vaginosis. Bacterial vaginosis is the organism is Gardnerella vaginalis and Mobilicus and Mycoplasmas hominis and Prevotella and Atomicum vaginae. These are the various organisms which will cause bacterial vaginosis. The transmission is mainly by sexual intercourse and hormonal changes, pregnancy, antibiotic administration, and use of nanoxynol 9, spermicidal products, and douching. They are the various ways of transmission of bacterial infection. Coming to the signs and symptoms, thin, grayish or white, homogeneous vaginal discharge. The patient complains of white homogeneous vaginal discharge and increased vaginal discharge and with fishy odor after intercourse. And alkaline pH. Bacterial vaginosis does not cause vaginal itching or dysuria. The treatment consists of metronidazole, that is fragile 500 milligrams orally, twice daily for 7 days. In asymptomatic cases, asymptomatic pregnant patients with antibiotics for bacterial vaginosis to prevent preterm labor can be given. Effect on pregnancy outcome, spontaneous abortion, premature rupture of membranes, and preterm labor is likely to occur with these infections. Chorioamnionitis and postpartum endometriosis may cause neonatal septicemia. Coming to the candidiasis is the fungal infection. Organism Candida albicans and Candida tropicalis. These are the causative organisms for candidiasis. Transmission cause of vaginal pH to more alkaline and high estrogen levels, causing increased production of vaginal glycogen. Coming to the signs and symptoms, vaginal or vulvar irritation, erythematous and edematous, and pruritic, white, curd-like vaginal discharge. Yeasty odor and dysuria and dyspareunia are the symptoms in the patient suffering from candidiasis. How to screen them? Saline or potassium hydroxide wet mount microscopically examined show hyphae, pseudohyphae, and budding yeast. Usually pH lower than 4.7. Whiff test absent and fishy, amine fishy odor it will give. Treatment in pregnancy, use an antifungal, anti-vaginal agent such as butoconazole, clotrimazole, and miconazole or turconazole, and have cis bath. Coming to the next disease, leprosy, Hansen's disease in pregnancy. Nowadays, the leprosy is almost eradicated. If we get the cases, the causative agent is a Mycobacterium leprae. With established leprosy, there is chance of exacerbation of lesions during pregnancy. However, the baby should be separated from the infected mother immediately after delivery. When the disease becomes quiescent and non-infectious, the baby is given to the mother. Dapsone and clofazimine appear safe in pregnancy. Coming to the next infection, gonococcal infection or gonorrhea. Organism Neisseria gonorrhoeae, and transmission is due to gonorrhea is transmitted by close sexual contact. The incubation period is 3 to 5 days. Coming to the signs and symptoms, the patient complains of vaginal discharge, may be profuse, purulent, and yellow green. Itching or swelling of the vulva, dysuria, dyspareunia, joint and tendon pains, and anal discharge, discomfort and pain with rectal infection. Screening is done by molecular diagnostics and endocervical culture. Treatment in pregnancy is cefixime 400 milligrams orally or one dose of ceftriaxone 125 milligrams intramuscularly. Sexual partners with the preceding 60 days should be identified, examined, and cultured and treated. Effect on pregnancy outcome. It can affect outcome of any trimester, causing chorioamnionitis, preterm delivery, premature rupture of membranes, and intrauterine growth retardation or postpartum sepsis. If the organism is present at the time of delivery, the greatest neonatal risk is gonococcal ophthalmia, which can cause blindness. Coming to the next sexually transmitted disease is syphilis. Syphilis is sexually transmitted disease caused by Treponema pallidum. Coming to the signs and symptoms, the incubation period is 10 to 90 days. These are primary, secondary, and tertiary syphilis. Primary syphilis, stage 1 is evident by chancre, which is highly infectious, painless, round, ulcerated sore that does not get better fast. It may last for 3 to 6 weeks. Secondary syphilis, evident by maculopapular rash. This rash usually exhibited between 1 week and third month, 1 week and third month after primary chancre. It is typically clear in 2 to 6 weeks, but can be lost up to 1 year. Other manifestations include wart-like genital growth, lymphadenopathy, fever, sore throat, patchy hair loss, headache, weight loss, muscle aches, and tiredness. These are the symptoms of secondary syphilis. Coming to the latent syphilis, stage 3 is usually asymptomatic. The spirochete goes to hiding for 5 to 20 years. The patient is seroreactive during this stage. During the first year of this stage, the patient is infectious. Coming to the tertiary syphilis, the first stage is reinfestation of the disease. It slowly destroys the heart, eyes, brain, central nervous system, and occasionally the liver, bones, and skin. Coming to the investigation, serological test VDR, Venereal Disease Research Laboratory. This is a serological test, what we do for syphilis. Fluorescent triponymal antibody absorbance test also done. Treponema pallidum microhemagglutination test, these are all very specific tests for syphilis. Treatment for mother for primary and second syphilis, less than 1 year duration. Benzathine penicillin 2.5 million units intramuscularly given in a single dose. When duration is more than 1 year, benzathine penicillin 2.4 million units intramuscularly weekly for 3 doses is given. For baby, positive serological reaction is single intramuscular dose of penicillin G, 50,000 units per kg body weight is given. For infected baby with positive serological reaction, isolation with mother, then intramuscular administration of aqueous procaine penicillin G, 50,000 units per kg body weight. each day for 10 days to be given. Then coming to the urinary tract infections, this may be asymptomatic bacteria, cystitis, and pyelonephritis. With this, the patient with UTI can present to us. So organism is generally E. coli, Klebsiella pneumoniae, Proteus species in recurrent urinary tract infection. Less frequent gram-positive causative organisms include B. streptococcus and enterococci and staphylococci. Transmission is by sexual intercourse and improper wiping after defecation. Coming to the signs and symptoms of urinary tract infection, the patient complains of urinary frequency, urinary urgency, dysuria, hesitancy and dribbling, and suprapubic tenderness, gross hematuria, and accompanying symptoms with pyelonephritis usually are chills, fever, and back pain with costovertebral angle tenderness. These are the signs and symptoms of urinary tract infection. To screen this, microscopic examination shows WBC. Bacteria may or may not be present. If bacteria is not present, we call it as asymptomatic bacilluria. Dip urine may be positive for nitrates and leukocytes, and clean catch midstream for culture and sensitivity. When we send the urine for culture and sensitivity, it must be a midstream urine, and you have to send it in a clean and autoclaved container. Treatment in pregnancy for asymptomatic bacteria and acute cystitis is antibiotic therapy for asymptomatic bacteria is effective in lowering the risk of pyelonephritis and preterm labor. Usually 10 to 10 days course is preferred. Treatment in pregnancy for pyelonephritis. The usual treatment is amoxicillin claviate or augmentin, 875 milligrams twice daily for 7 to 10 days, and cephalosporin are the drugs of choice in the treatment of pyelonephritis along with pregnancy. Effect on pregnancy outcome is the endotoxins released from gram-negative bacteria may stimulate the production of prostaglandins and cause preterm labor. Coming to the viral infections in pregnancy, this is AIDS or HIV. The HIV organism is a retrovirus of the lentivirus family that has an affinity for the T lymphocytes, macrophages, and monocytes. The transmission by infected blood or body secretion of semen or vaginal fluid. Secondly, unprotected sexual activity, sharing of contaminated needles, and pediatric HIV primarily results from perinatal or breastfeeding transmission. Coming into the immunopathogenesis leads to slow but progressive destruction of T cells. The incubation period is about 1 to 3 weeks. After a peak viral load, there is a gradual fall. More destruction of host cells, progressive immunosuppression, and opportunistic infections and cancer. This is regarding the immunopathogenesis of HIV. The patients present with fever, malaise, headache, sore throat, lymphadenopathy, and maculopapular rash. Secondly, constitutional symptoms like weight loss, lymphadenopathy, and protracted diarrhea. And multiple opportunistic infections with candida, tuberculosis, pneumocystis, and others. With these, the patient may present to us. The diagnosis is by enzyme immunoassay and Western blot test or immunofluorescence assay to be done to diagnose HIV. Coming to the management, prenatal care, voluntary serological testing for HIV, counseling has to be done and assessed by CD4 count and T lymphocyte count and HIV RNA at every 3 to 4 months interval. Highly active antiviral therapy, HART, that is nucleoside reserve transcriptase inhibitors are Gidovidin, Gilactimine, and Lamivudine and Stavudine. These are the drugs. And the next group are non-nucleoside reverse transcriptase inhibitors like nevirapine and delavirdine. And coming to the third group, protease inhibitors are indinavir, sequinavir, ritonavir. And the other type, entry inhibitors are efavirenz. There are various drugs we choose to treat the HIV. Mostly we use Gidavidin and nevirapine. These are the drugs of choice not nowadays. And coming to the intrapartum care, during delivery, Gidavidin is given intravenous infusion starting at the onset of labor or 4 hours before cesarean section. Loading dose 2 milligrams per kg per hour until cord clamping is done. Then in amniotomy and oxytocin augmentation for vaginal delivery should be avoided whenever possible. And effective cesarean delivery recommended at 38 weeks of pregnancy, women receiving any of the drugs like Gilead, etc. Coming to the postpartum care, breastfeeding can be given and Gilead syrup 2 milligrams per kg is given to the neonate 4 times daily for the first 6 weeks of life. Coming to the other infections, torch infection. This is toxoplasmosis. This is a systemic infection caused by protozoan Toxoplasma gondii. Okay. Then consequences of fetal infection. Why we are that much scared regarding toxoplasmosis? The classic trait of hydrocephalus, intracranial calcification, and chorioretinitis are the common results of toxoplasmosis. So we must be very careful in treating toxoplasmosis as early as possible. The common manifestations are mental retardation, seizure disorder, hepatosplenomegaly, and central nervous system involvement. Coming to the management, prenatal counseling, prevention, medication, pyrimethamine and sulfadiamine plus folinic acid ought to be given to manage toxoplasmosis. The other infection is rubella. This is RNA toga virus spread by nasopharyngeal droplets with an incubation period of 14 to 21 days. The disease prodrome of malaise, fever, headache, conjunctivitis, and pharyngitis lasting 1 to 5 days precedes the classic manifestations of widespread pink or red maculopapular rash and generalized lymphadenopathy. Effect of maternal infection on the fetus and newborn is spontaneous abortion, congenital rubella syndrome causing symmetric intrauterine growth retardation, congenital heart disease, and hepatosplenomegaly and thrombocytopenic purpura. Then coming to the central nervous system manifestation include deafness, eye lesions such as congenital cataract, retinopathy, microphthalmia, microcephaly, panencephalitis, brain calcification, and psychomotor disorders are the defects of or the effects of maternal infection on the fetus and the newborn. To manage this, immunization of all adult women and education of parents about dangers of rubella infection. All pregnant women should be screened for rubella antibodies at the first prenatal visit. Coming to the cytomegalovirus, it is double-stranded DNA virus that belongs to the herpes virus family. Humans are the only known host for the virus. The transmission is they are transmitted through blood via transfusion or transplantal route commonly and droplet infection, body fluid, semen, vaginal secretions, saliva, urine, breast milk, organ transplant, and rarely through direct contact. So, effect of maternal infection on the fetus and the newborn. About 15% of the infants are symptomatic, non-immune, eye drops, symmetric intrauterine growth reduction, and apoplexy, central nervous system sequelae like chorioretinitis, microcephaly, hydrocephaly, and calcifications. Almost 85% of infants are asymptomatic. To manage this, prenatal counseling is highly recommended. Drugs like ginseng flower, forcurrent, and cidofervir are to be given. The other infection, herpes simplex virus. Simplex virus is a member of herpes virus family. It is a DNA virus. The transmission is through intimate mucocutaneous contact. It is one of the most contagious sexually transmitted diseases. Then it causes spontaneous abortion, intrauterine growth retardation, fetal death, preterm labor, neonatal infection, and neonatal herpes. Management comes under acyclovir administered 200 milligrams 4 times daily for 14 days. And topical application of acyclovir cream and severe infection, intravenous administration of acyclovir 5 milligrams per kg body weight, 8 hourly for 5 days. Coming to hepatitis B infection, the virus is transmitted by parenteral route, sexual contact, and vertical transmission, and also through breast milk. The maternal infection, acute infection, is manifested by flu-like illness as malaise, anorexia, nausea, and vomiting. There may be acromegalia and skin rashes. Diagnosis confirmed by serological detection of HBsIg and antibody to hepatitis B core antigen. The management is rest, isolation, nutrition, drugs, and prevention of complications. So, human papillomavirus, Condylomata acuminata. The effects in pregnancies can grow more rapidly during pregnancy and are located over the genital tract and perineal region. They can grow so large as to cause dystocia and severe hemorrhage when disruption occurs during vaginal delivery. Management is the excision of lesion by cautery or use of cryosurgery. Parasitic and protozoal infections are malaria. Effects of malaria on the mother are anemia, hypoglycemia, metabolic acidosis, jaundice due to hepatic dysfunction, renal failure due to block of renal microcirculation, and pulmonary edema and respiratory distress. Convulsions and coma and can cause can occur in case of cerebral malaria. The effects of malaria on the fetus is abortion, preterm labor, prematurity, intrauterine growth retardation, intrauterine fetal death. These are the effects of fetus with the mother having malaria. Management, prevention from mosquito bites using mosquito nets and repellents. Prophylaxis with chloroquine, 300 milligrams base, orally once a week. Intestinal worms, chlamydia, organism, chlamydia trachomatis. Coming to the nursing management, primary prevention of sexually transmitted infection and secondary prevention, tertiary prevention. So nursing diagnosis, acute pain related excoriation from scratching, pruritus area, ulceration, etc. Impaired skin integrity related to presence of skin infections. Risk for complications are intrauterine growth retardation, spontaneous abortion, premature rupture membranes, preterm labor, and fetal death related to presence of sexually transmitted disease or other infections. Risk for fetal or neonatal infection, fetal malformations, and anomalies related to complications of maternal, torch, or sexually transmitted disease. Sexual dysfunction or affective sexually patterns related to perineal discomfort and prescribed abstinence during treatment. Self-esteem disturbance related to a diagnosis of sexually transmitted disease. Effective coping related to diagnosis of sexually transmitted diseases. Knowledge deficit related to disease condition, mode of transmission, fetal outcome, possible treatment opportunities, etc. Fear and anxiety related to possible fetal outcome secondary to the infections. To safely treat our infections during pregnancy. Thank you. Any doubts you can ask, any questions? Any questions regarding infections in pregnancy? No questions? Thank you.